So next I'd like to invite Dr. Manabjyoti Barman from Shankardeva Netralaya Guwahati for his talk on how to avoid intraoperative hemorrhage.
Good morning all, and thank you Dr. Devdulan and all my co-instructors. So I'm going to speak on how to avoid intraoperative hemorrhage in vitrectomy surgery. So despite all major advances in vitrectomy surgery, still intraoperative hemorrhage is a challenge in many of the complicated cases. And this is around 1/3 of cases have significant vitreous hemorrhage, and it can be necessary repeating the procedure in up to 13% of cases. This is a rough record of the vitreous hemorrhages. So bleeding may occur from different sources, blood vessels in the sclerotomy sites, any neovascularization, or any injury to even a normal healthy vessel can also lead to hemorrhage during surgery. And extensive hemorrhage may prevent successful completion of the surgery. So grades of hemorrhages, grade 1, grade 2, and grade 3, these are again rough grading of the intraoperative hemorrhages. So grade 1 is that stops spontaneously or with a minimum elevation of the IOP. Then grade 2 is that sheets of clots away from the source of bleeding and diathermy is required. And grade 3 is the thick clot that covers the at least half of the posterior pole and interfere with approach to the posterior plane. So mainstay to avoid intraoperative hemorrhages, one of the most important is the proper systemic control. And then preoperative anti-VEGF also has a significant role. Then peritoneal photocoagulation when it is applicable, and meticulous surgical planning is one of the most important steps. So coming to the systemic conditions that increase the risk of bleeding, this is the Hayes-Bleth score. So this is many of our new surgeons may be interested what is Hayes-Bleth score. It was originally designed for atrial fibrillation patients, but this later it is shown that it is applicable in almost all of the surgeries. H for hypertension, A for abnormal renal or liver function, then S for history of stroke, D for bleeding disorder, L for labor INR, that is the INR, that is the patient performing time divided by control performing time, and then E for elderly patient above 65 years of age, and D for drug or alcohol intake. So Hayes-Bleth score more than 3 is considered and high risk of bleeding, intraoperative bleeding. So peritoneal photocoagulation definitely it has a established role in preventing intraoperative bleeding, particularly in diabetic retinopathy. This diabetic retinopathy study shows that reduced risk of long-term severe visual loss, that risk of severe visual loss without treatment for eyes with moderate or severe NV increased from 6.9% to 29.7% in presence of vitreous hemorrhage, and risk of severe visual loss without treatment in case of NVD increases from 10.5% to 25.6%. And the endpoint of laser photocoagulation should be the complete resolution of NVD and NVE. So these are again, there are many studies that supports the role of PRP in preventing intraoperative bleeding. Then coming to the role of anti-VEGF, use of anti-VEGF agents before PRP results in superior functional and structural outcomes at 3 months to 4 months. Use of anti-VEGF agents before PPV results in decreased duration of surgery, fewer breaks, and less intraoperative bleeding. And use of anti-VEGF agents as adjuncts to PRP and PPV in complicated PDR helps in minimizing the iatrogenic damage. So multiple studies, meta-analysis, and Cochrane studies have established the role of anti-VEGF in case of in preventing intraoperative bleeding. So this is a case of ROP stage 4. You can see the radiating blood vessels coming out of the peripheral retina with a tractional retinal detachment. Fortunately, the patient has a attached posterior pole, and this already laser was tried in another center, but they could not prevent it. So patient has come to me, and we have planned surgery. But before going for surgery, I injected anti-VEGF 5 days prior surgery. So after injecting for anti-VEGF, after I have taken the case for surgery after 5 days, and you can see the bloodless surgery. I think nicely manipulate the membranes behind the lens, and there is not a single drop of bleeding from the blood vessels. So within 5 days, there is a complete reduction of the peripheral blood vessels. So this is one of the cases that shows the role of anti-VEGF in preventing intraoperative bleeding. So you can see the manipulation of the membrane is easy, and the field is also quite clear. So in diabetic retinopathy also we should anti-VEGF, you can use it liberally anti-VEGF in preventing intraoperative bleeding. So this is the end of the surgery. So surgical technique, meticulous surgical technique is essential. Careful dissection of membranes is one of the most important steps. Optic nerve proliferation should not be trimmed too short. So many a times there may be bleeding from the optic nerve head, and that needs cauterization. So if we trim the proliferation very close to the optic nerve head, so bleeding, it is difficult to prevent stop the bleeding, and any cauterization of what optic nerve head may damage the optic nerve head. So we should leave a small stump or the optic nerve head. Anti-intraoperative bleeding must be promptly controlled. Initial management includes elevating the infusion fluid container to increase the IOP, and if necessary, IOP should be raised further by increasing infusion pressure. So how much of IOP to raise? IOP more than 40 millimeter of mercury can be sufficient to reduce mean ophthalmic perfusion pressure below critical levels, can switch to a pressure IOP of 60 millimeter mercury on encountering a bleeder, and it should be brought to normal levels as early as possible, that is within 60 to 90 seconds. And gentle pressure can also be applied over the bleeding bleeder, and we can use a hem stopper also. So any blood on the retina should be removed immediately. Clotted blood should be cautiously stripped from the retina, if necessary by using the cutter or by another instrument, and reducing the IOP at the end of the vitrectomy is one important step to see whether any bleeder is there, potential bleeder is there. So diathermy is one of the most important instrument that helps in preventing intra bleeding. And high frequency proportionate coaxial bipolar is the source of diathermy, and already discussed that very heavy biothermy can damage the retina from atrophic holes, so it should be avoided. So making diathermy a multidimensional tool. So often during the surgery, while we do bleeding occurs, taking out the diathermy and sucking out the blood, and again using the diathermy is difficult. So what we do is, in my practice, I use a very high energy diathermy up to 100%. So I just hover the diathermy probe over the bleeding site and put the foot pedal completely, and some waves will come out, frequency waves will come out, and it will just form some sort of vibration and bubble formation around the bleeders, and the blood will be dispersed, and then I will release the foot pedal to around 30%, and I will apply the diathermy to the bleeder. So it is one of the, I find it is quite useful in regular vitrectomy surgery. So this is, you can see how diathermy can be applied. So all the diathermy sites should be properly dressed at the end of the surgery. So sometimes endophotocoagulation can also be used in small bleeders that helps in the coagulation of the blood. So fluid gas exchange and vitrectomy under fluid air exchange is also one technique in case of heavy bleeders. And so rarely in eyes with excessive bleeding, thrombin may be mixed with infusion fluid to accelerate the coagulation process and reduce bleeding. And other methods include viscoelastic, silicone oil gas, and perfluorocarbon liquids to prevent bleeding. So in conclusion, modern vitrectomy surgery enables more control of intraoperative bleeding, and given the seriousness and potentially blinding consequences of severe intraocular bleeding, it is reasonable to prepare the patients in advance, and that includes systemic control and careful surgical approach. Thank you so much.
Thank you, Dr. Manav. One question to you is, what would be your advice regarding stopping disc hemorrhage?
That is what this hemorrhage that I prefer, that I'll never cut it NVD very short to the disc, and so that I can cauterize the disc. And still, if it bleeds, then of course FG or silicone oil is the option.
Yeah. Regarding, could you please once more explain what you meant by 100% diathermy and the bubble thing that you mentioned?
That is what that whatever the new diathermy machines, particularly whatever comes with the Constellation machine, so it we can give the power up to 100%. So that is around 60 something. So whenever we press the foot pedal, so it will give the 100%. But with 100%, if we apply to the retina, it will instantly form a break. So I don't apply directly over the retina. I just keep it slightly above the bleeder.
Yes. So this is something very important that he mentioned, that with 100% cautery, if you touch the retina, then it's going to blast off the retina. So it has to be a little away from the retina, so there will be bubble formation, which will be good enough to take care of the bleeders. So this is, I think, a very useful step that we often follow. So